Hi, I'm Joni Beasley, and I'm here to present a brief overview of the START model. There are longer descriptions on our website that go into greater detail, but this will give you a thumbnail sketch about the model itself and many of the elements that are important to understanding both our project and the philosophy behind it. So first I want to start out by talking a little bit about why we do this work and who we're meant to serve. And we talk about the mental health aspects of intellectual and developmental disabilities. Many years ago, up until recently actually, this population of people that we're talking about might have been known as the dually diagnosed IDD population. We avoid using the term dual diagnosis because we don't really think that people are defined by their diagnoses. And also the diagnosis of having mental health needs is not really, it doesn't really encompass all that we're talking about when we talk about the mental health aspects of IDD. When we talk about the mental health aspects of IDD, we're talking about both mental illness, problem behaviors, but also how to promote the emotional well-being in a population that has suffered from great disparities over the years. And so it's really a combination, it's really a social movement that we're looking for, where people with IDD are more included in ordinary life, which reduces the likelihood that they will suffer from mental health conditions, but also will help to ensure that they have better emotional well-being overall. But what we do know, what is well known, is that people with IDD experience numerous health disparities, including higher rates of mental health symptoms and challenging behavior compared to typically developing peers. And that is a well-researched bit of information, which really speaks to the challenges that many people with IDD face. Mental health issues are often misdiagnosed, underdiagnosed, or undiagnosed, and even when detected, few evidence-based treatments exist. What this means is that for a long time, understanding and accepting that people with IDD had mental health needs falls way behind the general population and has resulted in these outcomes of poor diagnosis and also poor treatment, because many people with IDD were not included in research testing treatment methods. And I'm not just talking about medication, I'm talking about all mental health treatment methods. This gap has translated into costly and ineffective care and has resulted in frequent crises, emergency room and psychiatric hospitalizations, a very poor quality of life, and yes, even contributed to earlier age of mortality. This is an ongoing capacity challenge that didactic training alone doesn't meet. It requires evidence-based and local professional leadership development opportunities for educators, primary medical, IDD, mental health providers, police, and first responders, and training information to families. It actually, I would love to see a public health campaign so that people with IDD are better understood in the community in general. The system of care is siloed so that cross-systems collaboration is lacking, creating barriers to understanding and effectiveness. And the remedy needs to also include connecting those silos for better collaboration. So you will see in most states, in most systems, the silo, the separation between the mental health services and the IDD services. You'll also see separation between child services, adult services, and elder care services that also can impact the ability to really collaborate effectively and help a person have a better life and get the services that they need. Oh, and the other thing that happens is the collaboration between psychiatry and neurology can also be problematic. primary health care and psychiatry can be problematic. So the silos also exist in the healthcare system, which when people have complex needs or multiple treatment needs, that can be very problematic. So START, which is an acronym for Systemic Therapeutic Assessment, Resources, and Treatment, is an evidence-based model. And the focus of START is cross-systems crisis prevention and intervention services. And our population served are ages 6 and older, with a focus on people with intellectual and developmental disabilities and mental health needs. I am the founder of the START model, and the first project was developed by me and members of my team back in 1988. The Center for START Services, which was developed in 2009 at the UNH Institute on Disability UCED, is an organization of experts in the mental health aspects of IDD who develop innovative IDD MH training programs, conduct research, and facilitate the development of START programs across the country. All of the people who teach and practice and study START practices have been involved in START programs themselves. So it's really a growing field of experts through the START model and through engagement across the country and with each other in order to improve our practices. So back in 1998, I published a theoretical model to help describe what is effectiveness, because in the 90s, the late 80s and well into the 90s, people argued for effective services. And what they were really arguing for was they were advocating for one service or another. So people would say the system's ineffective, we don't have enough inpatient beds, or the system is ineffective, we need more places to send people for placements, or the system is ineffective, we need more prescribers. And what they were really talking about was access. They weren't really talking about effectiveness. And if you're in this field long enough, you'll know that access alone does not define effectiveness. There are actually 3 elements to effective services, which we really strive for in the START model and in our measures of the model itself in terms of evaluating the quality of the services provided. And they are access, appropriateness, and accountability. And access speaks to not only the services being around, but being around when you need them so that they're timely and available to all of you. So I remember data being collected in several states about whether or not people with IDD had access to mental health services. And pretty much every state in the United States would argue that some people in the state do have access to mental health services. But when you explore further through systems analysis, which is one of the things that we do to help states figure out exactly what version of the model they would like or what kind of practice improvement training they would need, we look at access as a very important thing. Are the services timely? Are they available? Are there long wait lists? Do you have few choices in who you have access to? There's one psychiatrist or one nurse practitioner. That is really not good access in terms of effective services. The second A is appropriateness. Do the services match your real needs? So if you have access to psychopharmacology, but what you really need is a job, does medicating somebody who's miserable actually look like the appropriate way to support that person? And so you really have to make sure that you do a very good needs assessment and understand the person very well before you access those services and make sure they match their needs. And appropriateness also really speaks to providing tools and improving capacity, that you don't just go someplace to be fixed, but that appropriateness really talks about how you become appropriate, what needs to happen, how you perfect your skills and your approaches. And then the third A is accountability. And this speaks to responsiveness, engagement, flexibility, and creativity. Accountability to the people we serve is extremely important. There are multiple levels of accountability that have to exist in an effective treatment system. The first level is to the person themselves. The second level is to the people who support them and their families. And the third level is to society at large. There are multiple levels of accountability that start with the person themselves and expand out further as we really look at effective service delivery. And as I said, I published this study, this research, this theoretical model back in 1998. And since then, which was about 10 years into the START model, we have been employing these 3 A's to measure our outcomes and to report our findings to stakeholders. And it has been very helpful to really think of things in this way. The UNHIOD Center for START Services, our real mission is actually capacity building. And when we talk about capacity, there are many areas in which we do this. But our 3 levels of capacity building are research, education, and implementation of the START model. And you'll see that we do a lot of work in this in order to be successful. So the first thing I want to say is that data is an objective measure to really understand what you're doing and how you're doing it. But having a database alone doesn't really help you to build that capacity. It's really knowing that everybody is putting in the data the same way reliably, that you're looking at the data regularly, and that you're using it to measure those 3 A's. And so the START Information Reporting System, or SIRS database, is a key element that we use to build the capacity of our model, of our partners, and of our practices. We also have professional learning communities, professional practice improvement groups, coaching, technical support, and we do have a certification program based on the START model for coordinators and programs. And we also do a lot of other educational forums, as you will see on this list here. We have recently developed the National Research Consortium, which is a partnership with other universities, researchers, and it has a lot of patient engagement and family engagement involved. And managed care organizations and private providers are our partners in this work in order to really build the capacity mission that START is so focused on. What we really see this as is a movement which continues to grow and learn as we continue to test our assumptions and work together in collaboration to improve our skills and therefore the capacity across the country to better support and serve people with IDD and mental health needs throughout their lifespan. The START model itself that we implement in those blue states, the states with the blue color in the map, is really based on a public health, World Health Organization model of primary, secondary, and tertiary care. And as you will see, in tertiary intervention, which is our crisis capacity, we really are facing the odds and having expertise in order to push things up for the person and their life into more expert support in secondary intervention, where we try to beat the odds from needing tertiary care, and then primary interventions which change the odds and really improve the life of people that we support. Everyone who is referred to START is having a difficulty or in crisis. So really this portrayal of promoting mental health and public and overall health of people who receive START services is an excellent visual of how we do our work. And as you can see, when you're in primary services up here at the top, your potential impact for intervention is increased, and your ability to serve many more and support many more people increases. As you go down into emergency services, the intervention options are much reduced and fewer people get the benefit of those services. This is the clinical team START model. I won't go into great detail about this except to say that it's very comprehensive in terms of the resources that are available, the services that are provided, the linkage, and the real dedication to building capacity across services and across places where people are touched in their daily lives. So it's an excellent portrayal of the current program. And you will see up here is your START clinical team. I am going to explain what they do in an upcoming graphic, so you'll see in greater detail how the START model actually works through your clinical teams. And here it is. So here is the START conceptual framework. And what I'm going to do is walk you through how people come into each of your START programs and what START coordinators do and what clinical teams do to help intervene and prevent the frequent use of crises and promote the well-being of the high-risk population that is referred to START. So here in the beginning, if you can see my arrow, the first thing that happens is and let me just start with this. Everything is happening through telemental health right now, but as we go forward, the interventions, and I'll highlight which interventions they are, will be in person. And the other interventions will be telehealth, mental health optional. So let's talk about what is happening now, but also what will happen once the COVID crisis is over. Right here in the beginning, that intakes, provisional crisis plans, assessments, and all kinds of tools are used here for START. There's a long list of tools that all of the START teams are trained in to actually look at the person and their system of support and evaluate how the START program can be of best assistance to them. The target, as you see in gray in the middle, is cross-systems crisis prevention and intervention. So START teams are not like case management teams or outpatient mental health teams, although everyone has a role in cross-systems crisis prevention and intervention. The START team's sole purpose is to really navigate with the system of care and through a very methodical assessment approach and training and consultation approach to really help the system and the individual have the most effective cross-systems crisis prevention and intervention plan so that the system of care has capacity to support that individual effectively. And that's really our mission. So we start with this. Through this assessment intake process, which in the beginning should be done in person, the first few meetings should be done absolutely in person. People are in crisis. Right now, they're done through telemental health because in-person contact is not allowed, but this will go back to being in person. All of these assessments, all of this information gathering, including a provisional crisis plan, which will be used from the very first day, all of that impacts what happens in this middle section. And this middle section, once COVID is over, these services will be provided either through telemental health or in person, and most likely through a combination of the two. There are some people who will prefer telemental health and don't want a lot of in-person contact, and they'll primarily receive these services through telemental health. And the reverse can be true as well. They'll want more in-person contact. But all of these services are really the heart and soul of what we do with START. And they include consultation. Consultation is the services provided by the START medical director and clinical director, usually a PhD licensed psychologist. And psychiatrist. They provide consultation, which ranges from a second opinion on medication, psychopharm reviews, diagnostic assessments, and the like. We also, the STAR coordination system and therapeutic coaches provide what we call therapeutic supports. Now, therapeutic supports sound very simplistic. It's a nice little heading to put in a box, but it's really very much more complicated than that. The STAR coordinator is given a lot of tools and strategies to figure out what exactly does this individual need based on this, and to try several things in order to be effective. And the list of therapeutic supports fills many manuals of START, including therapeutic coaching, but START coordinators oversee all therapeutic assessments and supports for that individual. So START coordination also provides a lot of cross-systems collaborative opportunities. We have what is called service linkage agreements, and every START program fosters larger agreements across systems to really help explain and examine what our role is versus their role as we're trying to work out cross-systems crisis prevention and intervention plans, and who's going to be involved in which team meeting and in what way, in what manner. The START coordinators also foster cross-systems team communications, which can be a series of meetings, but we also send notes, reports. We also do a lot of outreach to members of the cross-systems team. We help families navigate their doctor's appointments, for example, by attending with them to talk about what their concerns are, and as well as with people with lived experiences, of course. There's lots of helping the team better connect and communicate through cross-systems collaboration. A key element of what STAR coordinators do is called outreach. Now, right now, outreach is through telemental health. Outreach can be conducted through telemental health, but also often requires in-person contact. And one of the things that we're going to be studying is there something that you lose when you're not physically in someone's home or school setting when you're visiting? Outreach helps you to connect with the person so that they know there's somebody there who is considering their needs. Outreach helps you to connect with the system of support so they remember the START team when they need assistance. Outreach is extremely important in actually being able to see how people are doing over time. Outreach helps us to foster better communication and partnerships. And finally, training. Now, training is just one word, right? But the START program, all of the staff are trained and certified in the mental health aspects of IDD and START coordination. And this is a very intensive and comprehensive training, but it doesn't end there. We have practice groups for all practitioners, including physicians and psychologists. We have all kinds of training and competency building opportunities, including individual coaching hours for staff needing individualized assistance. We believe that STAR coordinators should be able to, by the time your team is certified, build your training capacity, and as they continue with the START network, be able to receive and disseminate the latest and newest training in best practices so that you don't have to worry about paying for or finding new trainings, and you don't have to worry about keeping up with best practices. All of START trainings are renewed every 2 years. We review and renew and update all of our trainings, and every year we come up with new trainings based on the latest evidence and the latest practices. So there is a lot of information and training through your START teams. And it is the START team's mission to not only train on a sort of didactic way like I'm doing here with you today, but actually to have materials so that if a family has a child with a specific genetic syndrome or has autism or other needs in which training would be helpful, they go through to help improve the understanding of the family and the individual themselves so that they can better care for themselves and their family member moving forward in their lives. Now, all of this information that I just reviewed, including what you're training people in, including all the things you're trying through the supports and coaching and outreach visits, all of this informs what we call the Cross-Systems Crisis Prevention and Intervention Plan, which is developed with the Cross-Systems team through all of these mechanisms and through STAR coordination. This is influenced greatly by what the plan is in terms of the 24-hour urgent crisis response and intervention. The crisis response itself for a START team does not end with stabilizing the individual in urgent need. Each crisis response for the START model requires debriefing and learning that then influences the cross-systems crisis plan. So you see this arrow going up. So every time there's a crisis response, we look at the plan and we're like, did it work? What didn't work? What happened? What was needed? Once we figure out what is needed, we go all the way back to the beginning and start with the quarterly assessment, consultation, linkages, outreach training, and then modify the plan. So this circle happens frequently. What we have learned from the latest research provided by our research associate at Johns Hopkins is this process for most high-risk individuals who enter START in terms of urgent crisis needs, cross-systems crisis planning, and the services of START doesn't really get resolved for about the first 8 months. It takes about 8 months of doing this over and over again and reviewing what you've done. So notice we don't blame the person. We don't say the system didn't do their job. What we really do is we continue to look at what are the assessment needs, and we do it over and over again for about 8 months before we get to what we're really striving for, which we call the mediators. Now, mediators are the necessary outcomes, the necessary mechanisms that need to be in place in order to meet your goals. So our necessary mechanism in order to be effective in cross-systems crisis prevention and intervention is the system as a whole has to have increased service capacity and support. So the system needs to feel like their capacity has increased and they have an increased understanding and the means and the tools they need to provide better support. Now, down below the mediators are what we call moderators. Moderators are things that kind of exist, conditions that exist for people that are served by START that we have found in the research need to be addressed in order for this mediation to occur, in order for this capacity building to happen. And what we have learned from the research is that race and ethnicity matter, that if addressing racial and ethnic disparities has to be part of the mission of all of these people and this team in order to build the capacity we're looking for. We've also learned that where you live matters. The setting you live in has to affect the way you implement the Cross-Systems Crisis Prevention and Intervention Plan and all of the associated strategies that we're talking about. Your level of intellectual disability is also something that needs to be considered, and that if you have several or even one chronic health condition, that really has to be addressed, or that will undermine the ability for the person to feel like they can move forward in their life and the system of support to be effective. And finally, employment. Employment is one of those moderators that has been very interesting. And whenever we talk about it, people go, of course, employment makes sense, right? Even when you are amongst those who are vulnerable, and at high risk of crisis entering the START system. If you have a job, it increases the likelihood that this process that we just talked about will be much more successful in a shorter amount of time. So employment, having a job, is very important for all of us, and it's very important for the people we support. A job, and I would honestly say being included in a school setting where you're not in a segregated, isolated school setting, basically having a meaningful life, which when you think about it, of course that's true, but it's something that we have to actually face because the research is showing us that it's a glaring truth. So there you have it. So we get to this mediator, which is increased service system capacity and support. And that really leads to the outcomes that we're looking for. So the first outcome, because people end up in crisis and emergency rooms, that we're really looking for and that the evidence through the START model has shown us is happening in the research, is there's a decreased use of and diversion from emergency services. So we know from the evidence of START that START programming and START supports result in decreased use of and diversion from emergency services. But simultaneously, it also leads to increased perceived quality of care on the part of caregivers and care recipients. And I would argue the increased perceived quality of care translates to providers who believe that they have an increased quality of their ability to provide care. So it's both on the part of the individual and also the system. Remember earlier I talked about the person, the practice, and society as a whole. So those outcomes really expand to that whole concept of if you have capacity, if you understand what you need to do and how to do it, you're more likely to perceive that what you're doing is effective, which makes sense, those 3 A's. And the secondary outcome, which is the whole enchilada, is increased mental health and stability and what we call perma. And I'll talk a little bit more about perma in a minute. So this is the START clinical team conceptual framework that the prior outline showed you. So let me go back for a minute. This team focuses on this work. And that's really the long and the short of START. And yes, it's complicated. There's lots of details to it, but I hope this really helps to let you see the distinct role of the START clinical team in your service system and how that might work for you as it has for the centers that currently provide START programs. So the mission is PERMA, well-being, and it's a concept developed by Marty Seligman at the University of Pennsylvania, and PERMA stands for positive emotions, engagement, relationships, meaning, and accomplishment. And on the right-hand side here, you will see a list of all of the activities that we would refer to as therapeutic supports that are provided by the START coordinator and therapeutic coaches. So you can see that there's many different ways in which the therapeutic supports that we input result in the PERMA at the end, the beginning of the model to the end of the model. And some examples are what we call strength spotting, really acknowledging the person, nutrition, exercise, a biopsychosocial approach, supporting people's positive emotions and their sense of accomplishment, mindfulness practices, yoga, music, art, dance, drama, supporting the ability to focus on interests and skills, finding things that put the person what we call in flow or in the zone, etc. So I'm not going to go through all of these, but this table really shows the intersection between that very first, like when you start on that road and the end result. Not everyone likes the same things. Not everyone likes to dance to bring them joy. we have to find in a very individualized way what engages that person, what puts them in flow. And PERMA is really the demonstration of well-being, and the words stand for, the acronym stands for positive emotions, engagement, relationships, meaning, and accomplishment. And these are all of the focuses of all the START therapeutic practices and all the dialogues that we have with the system of care. In order to get there, there's a plus to PERMA. And the plus is health and intersection between health, mental health, and the environment in which the person resides. So another very important element of what we do is we institute the biopsychosocial approach to diagnosis and treatment. And biopsychosocial approach really speaks to the intersection between the social life that you have, your physical health, genetics, your disability, the treatments you receive, and your overall psychological well-being, your sense of self-esteem, your temperament, your skills, your communication skills, your family relations and culture, and also history of trauma. So all of these things are incorporated into the diagnosis and treatment planning, which is another very big part of what we do. That assessment word is just one word, but we spend a lot of time understanding the diagnostic profile and the life profile of every individual in order to come up with the right therapeutic interventions and supports to get to PERMA. So it's a complicated road that we're on, but there's a lot of support in doing it and a national network that really helps foster this. So every individual gets the best practices that we could possibly provide every day. We are an evidence-informed practice, which means that we identify data needs, we collect the data, issues arise, and then new questions happen. We analyze the data, we share the results, and we use the information to modify and improve our practices. So one of the things that the START programs will tell you, even the ones that are just a year old in California, is that we continue to revise and change what we do, not in dramatic ways that undermine the establishment of the teams, but based on what everybody is learning together. And one of the things that helps us with this is we're very able to deal with challenges like fires and COVID and modify our practices based on the evidence because we are an evidence-informed practice. When we needed to move to telemental health, we did this as a community and as a country of START programs with great ease. And we're very fortunate that we are a best practice that is informed by the evidence, and the foundation of our practices, as long as they can be instituted in telemental health, have been quite successful. So again, research and evaluation is a very big part of what START programs are involved with. And we share this and our best practices with the National Research Consortium on IDD. So one of the things that you should know about being a START program is they are paid to think. And we are, in a way, a giant laboratory for best practices in the mental health aspects of IDD. And in doing so, and we haven't done enough of this yet, but we will be working toward actually partnering with all the giant laboratories that foster best practices in IDDMH. Because through these linkages, we will be better at what we do, and hopefully they will gain something from what we do. So we are going to really expand that, because you do have some centers of great excellence that we need to partner with in order to improve our own practices and also the capacity of the START teams. The other thing that's offered through the Center for START Services for anybody, not just START programs, including the first one listed, which is really for START programs and START model implementation, are professional development practice groups. So for the START program, these are the lists of things that are available for professional development. And they are based on the START model and offer these constant opportunities for training and development over time. And this is for professional development for START programs only. We also have professional development courses for the general community in the mental health aspects of IDD. Our current courses out of the Center for START Services include mental health aspects of IDD for mobile crisis teams, care managers and service coordinators, direct support professionals, and child community protective social workers. And these courses run periodically a few times a year, and individuals sign up for these courses. They're all remote and all provide certificates of completion and CEUs. And coming soon is a prescribing practices guidelines group for physicians and prescribers that will be facilitated by our medical director, Dr. Jen McLaren from Dartmouth Hitchcock Medical School, and will offer CMEs. So again, the START model has many positive outcomes, and those that have been measured in research include health and service data through the SERS database across the U.S. that have shown high rates of stabilization following crisis, reduced psychiatric hospitalization and emergency department use, and increased satisfaction with mental health and support services. I hope that you enjoyed the START film and have learned something about the START model in this presentation. We hope that you are encouraged by what you hear and feel interested in participating in the program and in the work that we do. And I thank you for your time.